Hello everyone, my name is Justina Kopek and I am a healthcare technology consultant at MIPS Technology, and I also have Vida Giacomavi-Chute with me, who is a healthcare technology engineer.
Hi everyone. So as Justina mentioned, our webinar today is going to be on MIPS, which stands for Merit-based Incentive Payment System, and it is one of the tracks in which you can meet MACRA, which is coming up in 2017. So if you missed the last week's webinar on MACRA and what MACRA is, it is a Medicare Payment Reform Act that affects all Medicare Part B participants. So pretty much your payments are now going to be reimbursed based on quality and value of your care, and there are different ways that you're going to prove that quality to Medicare. So last week we discussed that MACRA has two tracks. You can either meet MACRA by taking the MIPS route, which is what we're going to be covering today. That stands for Merit-based Merit Incentive Payment System. And that is kind of a combination of existing incentives, such as meaningful use, value-based modifier, and physician quality reporting system. So that's what we're going to be looking at today. The alternative to performing in MIPS for MACRA is being a part of an advanced APM. That is going to be a webinar that we're holding on October 6th. So if you're not going to be participating in MIPS based on what you see today and you think that you may want to explore the APMs track, then we invite you to join us on October 6th webinar. Okay, so at this time, before we get started, we wanted to offer one poll question and just kind of see where we're all standing. So Justina is going to throw out there our first poll question for the day.
Okay, so our first poll question is, have you participated in meaningful use or PQRS in prior years? All right, I'm going to close the poll. Looks like we got the majority of our votes in, and let's share the results. So it looks like 71% of you participated in both, which is fantastic. We're really excited to see such a high number because that means that you have a general understanding of what MIPS is going to throw at you. Two of the main performance categories in MIPS are actually PQRS and meaningful use. So they're just changing the name and the requirements slightly, but if you already have been reporting on these programs in the past, then you're on the right track and you'll be very prepared for MIPS. So Vida will actually discuss the performance categories, but PQRS is going to be quality, and meaningful use is going to be advancing care information. Value-based modifier was one of the programs that also will relate to cost of care or resource use. That's not something that you would have reported in the past, but they did pick up that number from your Medicare claims. 29% of you say that you haven't participated in either of the programs. So what you want to do to catch up is just start reading about MIPS and informing yourself about the performance categories. So the fact that you're here today is great because we'll give you the background and kind of guide you where you should begin. Okay, so I'm going to hand it back over to Vida.
Okay, thank you. So before we kind of start taking a closer look at MACRA, or at MIPS, excuse me, who's going to be affected and who has to participate in MIPS or in MACRA in general? And the answer to that is all ambulatory Medicare Part B clinicians. So for those 70% of you or 71% of you who have participated in meaningful use or PQRS before, the list of eligible providers was a lot shorter. So if you were a physical therapist, you didn't have to participate. If you were maybe a nurse practitioner or a PA, you didn't have to participate. In MIPS, they're expanding this list. So this slide here shows everyone that is currently supposed to participate in MIPS. If you don't, you're probably going to get an adjustment, and we're going to take a deeper dive into that a little bit later on. But as of right now, if you're a physician's assistant, a physician, so an MD or a DO, a nurse practitioner, a clinical nurse specialist, certified registered nurse anesthetic, certified nurse midwife, or a psychiatrist, you are supposed to be participating in the MIPS program. So there is a statute in the first 3 years to possibly expand this list, which means when CMS releases the final rule on November 1st, this list could very well include additional providers that aren't currently listed. So we're going to have to keep our eyes kind of peeled and open and update you guys as that gets released. So before we proceed any further, we're going to throw out a second poll question for you.
Okay, so the question is, do you have one or more practitioners eligible for participation in MIPS? Okay, I think we got the majority of our votes in. So I'm going to close the poll. And it looks like 88% of you say that you do have at least one or more clinicians eligible to participate. So again, that's great that you're here with us today and you want to start preparing yourself for participation in MIPS in January. The 13% of you that are not sure, what I would suggest is maybe if you're not sure because of the credentials that your clinician may have, just throw us the credentials of the clinician in the questions box, and then we can, at the end of the webinar, review who is in your office and let you know whether they are eligible or not.
Thank you, Justina. Okay, so let's look at when MIPS is coming into the effect, the MIPS timeline. Oops, sorry. Go back a slide. So we're going to look at the actual percentages and adjustments a little bit later on, but based on this timeline, your meaningful use, PQRS, value-based modifier, all of those individual separate incentives are sunsetting in 2016, which means this year. This is the last year you're going to report to meaningful use, PQRS, and value-based modifiers separately. So if we're looking at the MIPS timeline over here, you can see that 2016 is your last performance year for these separate programs. Starting January of 2017 is when MIPS kicks into place, which means we're going to combine all of these incentives, and your performance in 2017 is going to determine whether or not you get a payment adjustment in 2019. So we're going to go over these adjustments and the amounts and the positive incentives and a little bit later on in the presentation, but one thing to take away from this slide is that MIPS starts January 2017, which leaves you with from now until then to pretty much start getting ready and get ready for your reporting. Okay, so let's move into the next, or actually before we move into the next slide, we just have one more poll question for you, and that will be the last one for a little while. So let's get that taken care of.
So the question is, what is your Medicare patient volume? And the reason that we're throwing all these poll questions out at you is because we kind of want to get a feel for who we have with us today and make sure that you're in the right webinar and that if you are eligible, then you're taking the right steps to fulfill these requirements. Okay, we got the majority of the votes in. So results show that 22% of you have a Medicare patient volume of 10 to 39%. 22% of you have a Medicare patient volume of 40 to 59%, and 56% of you have a Medicare patient volume of 60 to 100%. So for that last group of clinicians, I can't stress how important it is that you participate in these programs. The deductions, as Vida just went over, are getting more and more extreme, and these single practitioner offices whose Medicare patient volume is the majority of their income, if they don't join these programs and report on the quality, they really are going to go out of business. So we're here to be on your team and to try to help you participate in this. So as long as you work with us, I don't have any doubts that you'll not only avoid the penalties, you'll be able to stay in business and also receive an incentive. We don't really want you to think of this as an incentive or a penalty program. We want you to think of it more as delivering high quality of care at an affordable cost. That's really all that it is. For those clinicians that have a Medicare patient volume of 40 to 59%, it's still really important for you to participate in these programs. But the reason that we split up the Medicare patient volume into these groups is just because of the way that it will affect your practice. So the less Medicare patients that you see, the less you will be penalized. But nonetheless, you still will have some sort of penalty if you don't participate And again, the goal is to just show CMS that you are delivering high quality of care at an affordable cost. So if that's something you are already doing, why not submit your numbers and join the rest of the world and participate in the program as well.
Okay, thank you, Justina. All right, so let's take a look at what MIPS actually is. MIPS has 4 performance categories. As I mentioned before, up until this year or now, you've been reporting meaningful use, PQRS, and value-based modifier if you have been recording those separately. These were 3 separate incentive programs which if you participated in, you probably got an incentive. If you didn't participate in or did and didn't do so well, you probably got a negative payment adjustment. What MIPS is doing is it's combining all of these 3 incentives, all of these 3 separate incentives, such as PQRS, meaningful use, and value-based modifier into one. On top of that, it's adding a 4th incentive, and that's going to be your performance. So this is the CPIA category. We're going to look at each of these categories a little bit later on, but it's pretty much going to combine all of these plus add the CPIA, which is your clinical practice improvement activities category, and it's going to score you at each of those categories until they add up to a composite performance score of up to 100. So what CMS is going to do is it's going to have quality category, which is pretty much what your PQRS used to be. On top of that, it's going to take the ACI, Advancing Care Information is what it stands for, which used to be your meaningful use. Combine that with resource use, which used to be your value-based modifier, and add the CPIA, which is your clinical performance or clinical practice improvements activities category. And it's going to allow for the total score of that to add up to 100. Now, whether or not you get the 100, it's up to you. It depends on, you know, how well you put in the system or how well you put the information into your EHR, what the other thresholds for the other providers are. So the scoring on that will vary. But the way they've determined this so far is your quality or your PQRS will be 50% of your composite performance score. Your ACI, which is your meaningful use right now, will be 25% of your composite performance score, and your resource use will be 10%, and then CPA will be 15%. So depending on how, you know, what you score in each of these categories, they'll add that up, and you could potentially get up to 100 in the composite performance score. Now, what they're also going to do is they're going to have, it's a sliding scale. So your composite score, let's say you get 98 and the average composite performance score, let's say, is 60. You're well above the average threshold, which means you're going to get a positive adjustment. If you're below that threshold, you're going to get a negative adjustment. So it's a sliding scale because what they're doing now is they're going to compare your performance to performance of other providers. We're going to get into the whole how that affects your reimbursement a little bit later on, but MIPS it's a budget neutral incentive, which means one physician's loss is another physician's gain. So they're going to, what I'm getting at is they're going to determine these thresholds and they're going to score the physicians against each other. And see who gets a positive, who gets a negative, or potentially in neutral adjustment. So let's take a look at these performance categories a little bit closer and individually. The first one that I mentioned was your quality category, which is very similar to what you formerly reported for PQRS. So the difference is that for PQRS, you reported on 9 measures, which had to be distributed across 3 domains. And if you didn't do that, you're probably starting to maybe see, if you've logged into the CMS portal, maybe you see a feedback report now that indicates that you have negative adjustments. If you did well, maybe positive adjustments. But the difference between what you had to do for PQRS and what you're going to have to do for quality category for MIPS is that you're no longer reporting on 9 measures, you're only reporting on 6. You also no longer have any domain requirements, which means, the distribution where you had to pick 9 measures and spread them across those different domains no longer exists. You can pick any 6 measures as long as one of those measures is a cross-cutting measure. And what I mean by that is it's a measure that applies to a large volume of your patients. An example of a cross-cutting measure would be something like tobacco cessation, where you're lecturing your patients that smoking is bad and that they should quit. Another example of one cross-cutting measure would be documentation of patients' medications in their medical records. So it's pretty much something that applies to a very large number of your patients, despite of their age or their gender or the conditions that they have. A second one of the 6 measures that you select has to be an outcome or a high priority measure. So an example of an outcome measure would be something like, for diabetic patients, hemoglobin A1C checks. If you're doing hemoglobin A1C checks frequently and maybe educating your patient on what they need to do to keep their hemoglobin A1C levels below 9%, then that would be an outcome measure. And so there are a variety of these measures, and all of these are on the CMS site. If you need us to send those to you, that's something that we can do as well. But 2 of the 6 measures that you pick have to meet these requirements. One has to be a cross-cutting measure. One has to be an outcome or a high priority measure. Now, on top of that, CMS is going to look at your claims, and it's going to select 2 or 3 measures from your claim data for acute or chronic conditions. Now, whether they select 2 or 3 will depend on the size of your practice. If your practice 10 physicians or less, it's going to select 2 measures. If you're a practice of more than 10 physicians, it's going to select 3 measures from your claim data. And so you're really still reporting on 8 or 9 measures, except for you're actively doing it on your own on the 6th, and then they're taking the other ones from your claims data. Okay, each measure is going to be worth anywhere from 1 to 10 points, so you can potentially get 80 points maximum for the quality category if you're a practice of 10 physicians or less, or 90 points maximum for the category if you're a larger practice. Now, whether you get 1 or 10 points for the particular measure that you're reporting depends again on what they set as that threshold. So, they see that everyone's doing really well with documenting their medications, then the threshold for that particular measure is going to be higher. And if you score below it, you're going to get a lower number for this particular measure, which means you're also going to get a lower number for the total quality points in the quality reporting category, which is going to lower your composite score that we looked at that adds up to a potential 100 points. So it is important that you don't just do it, but that also you do it really well, because as I mentioned before, this is a sliding scale where they compare your performance to the performance of other physicians in the program. You are able to get a bonus point, so you get bonus points for recording an extra outcome or high priority measure. You're only able to get up to 2 points for each measure, so you'd have to report quite a few to make up for the loss of potential points, in the 6 that you will maybe report and don't do so well on, if you don't do well on. But you do have an ability to earn bonus points. We want you to be aware of that, because even with PQRS, we always said, when you're running your reports and you're tracking your progress, have backups. So if they require 9, make sure that you try to do well throughout the performance year on at least 12. Or if they require 6, make sure you try to do well on at least 9. Always have backups and kind of track your reports and see how you're doing throughout the year. For those physicians who have participated in PQRS before and maybe did it on their own, you probably are familiar with how to run a clinical quality measures report. If you're not familiar with that, that's something that we can certainly show you. So if you have an EHR system such as Medisoft Clinical or LikeMD, the best thing you can do to kind of see how you're doing within the quality performance category is to run your clinical quality measures report. It will give you a list of measures. It will show you how you're doing with regards to numerator, denominator, and percentages for your measures. And it'll give you a good baseline to start to see where and what activities you want to improve on and you'll want to report on. Another thing you can do is, if you have submitted to PQRS in the past, there are feedback reports. We're probably we don't have a date picked yet, but this may be something that we should do, is if there's interest out there, show you how to read these feedback reports, or potentially hold a webinar on that. But that's another thing. You can log into the CMS portal and get the feedback report on your performance on PQRS, and that will also give you a very good idea of how you're doing based to performance of other physicians. So there are things that you can do today even to see how well you could potentially do in this category. For those physicians who are specialists, and maybe some of the measures, they have added a lot of specialty expanded measures. So I know part of the issues that we've faced in the past is that we have someone who is maybe an ophthalmologist, and they're having a very hard time picking these clinical quality measures because there's just not a lot that apply to their specialty that are available in the EHR. They have expanded this list of measures. So there are a lot more specialty specific measures that you will be able to select from. And if for some reason you still don't have enough to report on for your specialty, what they're going to do is they're going to take the weight, the 50% of your composite score from the quality category, and distribute it into the other category. So if you can't meet the 6 measures in the quality performance, they're going to reduce the weight that the quality category has on your total composite score and distribute that to potentially meaningful use or value-based modifier, kind of distribute that score out evenly. But you're going to have to prove, that there's nothing you could have reported on. So that's kind of another bit of a headache to go through. Now, with the way you can report to quality is, obviously you can use your EHR system. That's actually what we encourage you to do. It's easy. You can track your own progress. There are fields in which you put in the information. Those fields are consistent. You can run reports and see which patients you didn't put the information for. It's just easier. You can also do claims-based reporting, which means you have to make sure that your biller, puts certain diagnoses and procedure codes for applicable population. I think that's a little harder because now you don't, when you're logging into the EMR, you can have an alert set up that can tell you, okay, this is a diabetic patient, so I need to do this, this, and that. You don't have that with claims. Someone's responsible for remembering to put specific codes that CMS and Medicare want to see to make sure that you're reporting correctly. You can use either a qualified or a qualified clinical data registry. So if you've used them in the past for PQRS reporting and that's convenient for you, you can continue to use your registry to report on the quality performance category. Now, as I mentioned before, this is 50% of your total composite performance score. So this is one of those categories that has the highest weight. So just to recap, the most important thing to take away for this slide is, if you have an EHR and you're not familiar with what a clinical quality measures report is, let us know. We need to show you how to run that. If you are familiar with it, forgot how to run it, let us know so we can remind you. And if you do know how to run it, go ahead and do so, just to kind of see where you are with each measure. Try to go on CMS site, or even look at your measures report and try to start picking what you could potentially report on, and brainstorming how and where are you going to be able to put that information to make sure that that the reports are able to pick that up. If you participated in PQRS before, like I said, log into the CMS portal and look for your feedback report. Some of them were not available just yet. CMS mentioned that these may come out on October 1st. So if you log into the CMS portal and you don't see your feedback report today, make sure that you follow up within the next few days and into next week, because they are going to be releasing those feedback reports. So between your clinical quality measures report and the feedback report on the CMS portal, these are the 2 ways that you can make sure you kind of find out where you are now and what you can do and where you need to improve. Okay, so that's your clinical or your quality of your MIPS category. Let's move into the next category, and that's ACI. Advancing Care Information, or formerly Meaningful Use, is your second performance category of the 4 in MIPS. And that's almost the same thing as Meaningful Use with some slight changes. So for one, some of the measures have been eliminated. So for those physicians who before had a hard time meeting CPOE, computerized physician order entry for labs or for radiology results, or maybe didn't do clinical decision support rule, you no longer have to do those. So there are several measures that have been taken out of meaningful use, of the ACI category that were previously part of meaningful use. Another thing to know is that it is no longer an all or nothing approach. So with meaningful use, you know you had specific measures. You had to report on all of those measures. Some of them you were able to claim exclusions from, others you were not, but you had to report on all of them. ACI in MIPS is not an all or nothing approach, which means before, if, for example, you failed a specific measure, such as e-prescribing, you failed the entire meaningful use. That is no longer the case. You don't fail if you fail to perform on one measure. That means you can still report on other things and still get a score for the advancing care information category. Now, the way that the scoring works is you get 50 base points, and then so it's 50 base points, and then you get also you can have up to 80 performance points. Now, the 50 base points you get for reporting non-zero or yes to these measures. So you're going to be, if you're looking at these, you're probably very aware of what they are if you have participated in meaningful use. Protect patient health information. For those of you who've done meaningful use with us, we've sent out these huge Excel documents that contain your IT information and your backups and your plan B in case of a natural disaster and things like that. So protect your health information still remains in the advancing care information performance category of MIPS. So does the e-prescribing, so does the patient access to the patient portal, which means those of you who don't currently have a portal, you will need that. Care coordination, so you probably should have a care team within your office and with other providers for the patient. Health information exchange, so this is your referrals where you're sending a patient out to say a different specialist and you provide them with a summary of the patient's chart. And then public health and registry reporting, which is either your immunizations, syndromic surveillance, or if you're currently part of any registry that is part of your base score as well. So here, it kind of does, and it doesn't matter how well you do in this particular 50-point base score, because you get credit just for reporting either a numerator and denominator that's higher than 0 or yes. So to protect health information, it's going to be a yes or a no. For e-prescribing, it's going to be a number, a numerator and a denominator, and so on. So if you either say yes or report a numerator and denominator that's higher than a 0, for all of these, you automatically get a 50-point base score. Now, one thing to note here, I have a star next to the protect patient information. If you say no to this measure, you can say no to some of these and get lower than a 50-point base score, but you'll still be able to report to the ACI category. This is one of these things you cannot say no to. If you say no to protect patient information, they're going to fail you for the entire ACI category. So it's something to keep in mind. If you don't have an IT that you work with, make sure that you contract one. You need to have your backups, your firewalls, everything in place to make sure that you can attest yes to this. Okay, so as I mentioned, just reporting on these, you get a 50-point base score. Now your quality focuses on 8 available measures, and the measures kind of span between patient access and health information exchange, and so they have a list of these different 8 measures, and you have to pick which ones you want to report on, and then you get scored on them. So before, here's the other difference between this and meaningful use. Before, for meaningful use, if you just passed the threshold, let's say the requirement for a measure was 50% and you were at 51, if you just passed the measure, you were good to go. Here is where your performance actually matters, because if you just get 50 points, you're not going to do so well as a physician who reports on these additional measures and does well in them. they're going to have a higher score for the ACI category, which means they're going to have a higher composite score, which means they're raising the average threshold, and so you want to make sure that you don't fall behind that. So each measure, like I said, there are several ones to pick from. Each measure is going to be scored from 1 to 10 points, and depending on how well you do and what the threshold is that CMS establishes, they're going to score you on that. And so you can get up to 80 points for your performance score if you report on all 8 of those. So as I mentioned here, percentages do matter. It's no longer enough to just reach the threshold. You want to make sure you surpass it. You want to make sure you do as well as you can, so that you kind of stay afloat and don't get penalized. Okay. There is a potential for a bonus here as well. Unfortunately, the bonus is only 1 point. So it could make a difference. It also couldn't. It is reporting to a registry. So if you do report to a registry currently, or you plan on doing so, you could also get a bonus reporting point in this category. Okay, and then your reporting possibilities, again, are either through an EHR, a qualified registry, or a qualified clinical data registry. You cannot do claims reporting here because there's no claims-related data really. So this is, for this particular performance category, we also recommend that you use an EHR. And the way that you can kind of see how you're doing now and how well you could potentially do in MIPS is run your meaningful use performance report. For any of you who have already participated in the past in meaningful use, you're familiar with what that report is, run it. There are some measures on it that are no longer part of the ACI or won't be part of the ACI, but a lot of the measures such as access to the patient portal, your referrals, your e-prescribing, things like that are still part of the ACI. So focus on those categories to see where you fall or where you would fall within 2017. If you see that you're just barely passing the threshold, you probably want to pick it up and try and start performing a little bit better on those measures. If you're not familiar with how to run this report, let us know so that we can follow up with you. Okay, so let's get into the third performance category, and that's resource use. So resource use is what was formerly known as value-based modifier. If you're a physician and you have someone that takes care of your billing for you, you probably aren't too familiar with what that is, just because this information was previously extracted from claims. So there's not really a separate reporting that you needed to do for that, and it kind of remains that way. You don't actually have to do anything to report on it. CMS will extract that data from your Medicare claim, from your Medicare claims. So it says here CMS Medicare claims data analysis, and that's what I mean by that. They're just going to look at your claims and extract 2 measures of some sort of chronic condition or something that meets your specialty, and then score you on that. Now, the scoring here is they're going to take a minimum of 20 cases for that particular diagnosis or whatever it is that they score you against, and they're going to see what your total cost for that measure for those 20 or more cases was. They're going to have target costs based on how well other physicians, of what the costs were of other physicians, and going to establish a threshold. Let's say for a specific condition, they allocate that you should have spent $13,000 for an X amount of cases. If you go above or below that, that's what your incentive or negative adjustments are going to depend on. So they're going to set up what is an average expenditure or target expenditure for that particular condition or measure, and they're going to score you against that if you go above or below that. So there are reports available to see what these things were in the past. So you can kind of, the way that they do is they'll take the existing value-based modifier numbers from within the last 2 years, and they'll set their threshold for 2017 based on that. So there probably is information that we can find online already about what target expenditures might be. Okay, you can get up to 10 points per measure for a maximum of 20 points. So depending on how, how much over the target expenditure you spend, or how far below it or under it you are, that's what's going to determine whether you get anywhere from 0 to 10 points for a particular measure. Again, there's no separate reporting that you have to do for that. It's going to be extracted from your claims. One thing to say here is if you don't meet the minimum of 20 cases, just like with a quality category, what CMS is going to do is it's going to take the weight of the total composite score that the value-based modifier category is, and they're going to distribute it against the other, or through or across the other categories. So if you can't, for one reason or another, report on this, then they're going to take the weight of your total composite score and maybe add some of it to quality, some of it to meaningful use, the ACI, or one of the other categories. Okay, and so let's look at our last performance category. And the last performance category is clinical practice improvement activities. And so CMS is going to offer 90 quality improvement activities, and these are going to be available in the 9 categories. I've listed the categories for you here below. It goes from expanded practice access, beneficiary engagement, achieving health equity, and so on. So these, are the 9 available categories, and within these categories you have 90 quality improvement activities that lay within them. So, for example, for an expanded practice access category, they want you to develop some sort of an activity or something like that that would expand patient access to your office for 24/7, for example. So, I mean, if you look at these, there are different things, but it could be emergency preparedness. So, like in case of an emergency, that a patient has better access to the physician. So there are different activities within these different categories, and you have to pick ones that you want to report on. Now, you can get a maximum of 60 points for this category, and the activities within these go from medium to high weight measures. So for a medium measure, you get 10 points. For a high weight measure, you get up to 20 points. So what you would want to do is you'd kind of want to see how many of these you can report on, how well you think you would do to try and get 60 points. And the reporting here, again, you can do either EHR, claims, qualified registry, or qualified clinical data registry. So this is a new category. It wasn't part of, or it wasn't a separate incentive in the past. So what you'd want to do is you'd want to start taking a look now at these categories, see the activities that lay within them, and try and piece together which ones you would potentially do and could do. And then, if you're interested in reporting through an EHR, what we will need to do is set up fields for you to be able to input the data for these particular categories so that we can run reports off of them later on. Because, when you go and attest to MIPS, and we don't know what this attestation process is going to be like just yet, but when you go and attest, you're likely going to be, kind of like what you did with meaningful use in PQRS. You're going to be putting yes, no, percentages. They will probably audit and do audits on providers in MIPS categories just the way that they did with all the other incentives. And so we want to make sure that we can run and produce reports that we have concrete evidence that you were able to meet these measures. So from this slide, what you should take away is there are 90 quality improvement activities for this category. You can get a maximum of 60 points by reporting different measures. Access and find these measures. We can send them to you if you have interest. They're readily available on the CMS site and Google and whatnot, but if you need them, we can send them to you. Take a look today and decide what you would want to report on. And then we need to start brainstorming how and where you're going to input that information. Okay, and so these are your 4 performance categories of MIPS. I've just kind of put them all together in a slide. It looks very similar from the slide that you saw before, but it's a summary. So MIPS has 4 performance categories: quality, which was formerly your PQRS, your ACI, which was formerly meaningful use, resource use, which was formerly value-based modifier and is only reported through claims, and your CPIA, which is your clinical practice improvement activities category. Through the 4 of these, you could get a total composite score of up to 100 points. You want to make sure your composite score is as high as possible because MIPS is a sliding scale, which means they compare your performance to that of other providers. They're going to have a threshold which you're supposed to meet, and you want to make sure that you're the provider that is above that threshold so that you can not only not get adjustments but also get incentives. Okay, so let's look at the consequences of what happens if you do or do not report. Let's focus on the slide to the right first, the MIPS payment adjustment. So this is your baseline fee-for-schedule payment adjustments. And so in 2019, you have a 0.5% increase on your fee schedule. From 2020 to 2025, the physician fee schedule freezes, which means there's no annual update. And then starting 2026, it starts back up at 0.5% annual increase. Now, again, adjustments are based on your performance composite score, so you want to make sure that you're above that score to make sure that you get a positive 0.5. Okay, now let's look over to the left-hand side at the MIPS payment adjustment. These numbers are a lot more significant. So the way that MIPS adjustments work is it's a 2 years, the payment adjustments reflect 2 years from the end of the performance period. So if your performance period, and not if, it definitely is, starting January 2017, that means that your positive or negative payment adjustments for 2017 performance year are going to reflect in 2019. Following the same model, your 2020 performance is going to reflect in 2022 payment adjustments, and so on. So if, for example, you don't participate in 2017, for one reason or another you decide that you don't want to do MIPS, or you don't do well in it, your negative adjustment in 2019 for this failure to perform in 2017 is going to be up to 4%. It caps out at 4% in 2019 for 2019. Now your positive adjustment could be up to 3 times the negative adjustment. There's some math involved here that CMS released. They have this quality neutrality factor, and that's what can get it up to 3%. I won't get into that today. If you want to know the specifics of how they justify this, I will be more than happy to sit down with you and go over it. But your positive incentive payments could be up to 3 times the max negative adjustment. So just kind of taking a look at this, you can see that as the years progress, your negative adjustments could go up to as high as negative 9% in 2020. So for those of you who do see a larger number of Medicare patients, that is a significant amount. Now, on top of the 3 times the negative adjustment positive incentive payment, you could get an additional 10% incentive if you're in the top performance list. So if you participate, do well, and do exceptionally well, which means fall within the 25 to 30% of the top performers, you get an additional 10%. So for 2022, on top of the potential 27 incentive, you add the 10%, and you could have as high as a 37% positive incentive payment on your Medicare Part B. So, I mean, these are significant losses, even more significant incentives. They're worth for you to take a look into it and explore a little bit further. Okay, there's no question about it, though. If you don't participate in 2017, you're going to see a negative adjustment in 2019 of up to 4%. If you don't participate in 2018, you're going to see a negative adjustment of up to 5% in 2020, and so on. And that negative adjustment increases up to 9% and taps out at 9%. Okay, so at this point, we want to throw out our last poll question, or one of our second to last poll questions.
We got two more. So the question is, what are your MIPS goals? All right, we'll go ahead and close the poll here and share the results. So if you're feeling overwhelmed or lost, that's okay. We're here to help you. We understand that this is so much information, especially if you're kind of just jumping into these programs last year and this year. Don't worry, you'll be able to catch up, especially with our help over here. So 82% of you said that you would like to achieve the highest quality of care and receive your incentive. So based on the adjustments that Vida just went over, you can see that, yes, the penalty is significant, but the potential incentive at hand is just, it's crazy high. So it's worth participating in these programs to even to receive that 9% or up to 27% incentive in one of the last years. 9% of you would prefer not to report. I hope that's not because you feel like it's too much work. If it is, then let us persuade you and try to work with you to show you how it can be easy and kind of incorporated into your daily workflow, where you are just focused on delivering your high quality of care at an affordable cost, and we're taking care of everything for you in the back end as far as making your progress notes compatible, running your reports for you, and tracking your progress. Don't let other providers take your money. You're working hard for that money. You shouldn't be giving it away to other providers. So if it comes to like I said, it just being not enough staff in the office, let us work with you and try to help you report. 9% of you are waiting on a clinician to make a decision. So what I would recommend is having a serious meeting between the clinician, who could be the provider, maybe a nurse practitioner, whoever else you have in your practice. Have a serious meeting with them, the office manager, and kind of develop a plan for what your goals are for this program. Preparation is key to performance, and if you kind of jump into this blind and you don't really know what your goals are, what you want from this, you're kind of just gonna be, you know, the blind walking the blind. So you want to have a clear vision for what you want to achieve with this. That way, you have something to work towards. And there isn't anyone that doesn't know or needs help. I think that everyone needs help. So whether that's help from us or just help from resources online, but we can also provide those for you. All right, and we're almost finishing up here. Back to Vida.
Thank you, Justina. All right, so let's take a look at who could be excluded. As with any incentive, there are buts. So I did mention before, or I gave you a list of the physicians that have to participate in MIPS. There are some exceptions. So if you're a first-year Medicare Plan B participant, you can be excluded from the performance in 2017. However, you will have to start reporting in 2018. So if you are a first-year Medicare Plan B participant, you have some more time to get your things in your office ready than anybody else does. Okay. If you bill in less than $10,000 in Medicare charges and see less than 100 Medicare patients per year, please notice the and here. It's not an either or. You have to meet both of these in order to be exempt from MIPS in 2017. So you have to make sure that you don't bill a cent over $10,000 in Medicare billing charges and that you don't see any more patients than 100 per year. So that's very important to make sure that that you make a note of the fact that this is an and. If you are participating in some advanced APMs, like for example Medicare Shared Savings Program Track 2 or 3, or if you're part of CPC Plus, some PCMH models, I would need to, if you are participating in those, I would need to know what those are to kind of give you a definitive, yes, you are exempt from MIPS or no, you're not. But some advanced APM participants could be excluded from MIPS. If you're a non-Medicare participant, so one very important thing, MIPS is a Medicare program, which means, if you don't see any Medicare patients, you don't have to do MIPS. Other payers, private payers, however, will adopt similar models in the coming years. I mean, that's always the case with them, right? They kind of just sit, watch back what CMS does with Medicare, how well it goes, and then they either jump on it or decide not to do it. This is going to be one of those things that they start implementing too. They're just going to first see what happens and how it unfolds with Medicare. But currently, if you don't see Medicare patients, you could be, or you are exempt from MIPS. And then clinicians in rural health clinics or federally qualified health clinics are also excluded from MIPS in 2017. So if you meet any of these criteria, then you would be excluded from MIPS in 2017. So with that, we're going to throw out there our last poll question. We do have more slides coming up. Some very important slides regarding participation in 2017, so make sure you stay tuned.
Okay, our last question is, how many more years does the clinician eligible anticipate to remain in practice? Okay, I think we got the majority of our votes in, so closing the poll. The reason for this question was kind of just to tailgate onto my previous point about having a serious meeting between the clinicians and the office manager at the practice, because you want to weigh the potential incentive against the potential penalty. So if you have less than 5 years in practice and you haven't implemented any electronic health record technology, maybe you want to weigh the cost of implementation you do have to implement a portal and then you have to be trained. And if you feel as though maybe that cost will be more significant than your loss, then you may not consider participating in MIPS. That would probably be one of the only reasons I would say you shouldn't participate. If you have more than 5 years, I think that the potential gain is higher than the potential loss, even with the implementation of electronic health records. And every year, more and more providers, we already have over 85% of the country on electronic health records. So more and more providers are jumping on this, and more offices are having a patient portal eligible. Our world is in healthcare is just becoming so interoperable. That's the whole goal of electronic health record technology and what CMS is trying to accomplish with all of their programs. So I would encourage you to hop on that, even if you think that the majority of your patients are elderly and they are not very cooperative. It's also coming from the staff. If the staff is not trying to encourage them, and if you already have a negative view on this, then your patients are going to as well. I'll leave it at that here and hand it back over to Vida.
Okay, thanks, Justina. So our last and probably one of the most important slides for the day is there have been some updates to MACRA coming in 2017. So there's been a lot of pushback from physicians and from physician offices and organizations regarding there not having been enough time for the physicians to prepare for this. As you saw, the incentives and the adjustments are great, and they could really have a negative impact on many of the doctors. And it could potentially, the doctors could be more ready and get more ready if they just had a little bit more time. So with that, one of the options that you now have, if you feel you're definitely not ready to report, is a testing option. So that's number one. You have to submit some data to the Quality Payment Program, MIPS, even if after January 2017, to avoid the negative adjustment. So with this option, you don't have to participate for a full year in 2017. You will not get an incentive, but you will potentially get no negative adjustment. So you're kind of remaining neutral. So if you feel that you're definitely not ready to attest, if you have never done meaningful use or PQRS before and kind of want to get your things together and kind of prepare for the program, then what you can do to avoid the negative penalty is just test, and that requires submitting some data to Quality Payment Program. Now I have some in capital letters here because CMS has not yet defined what the sum is. They're going to release the final rule on November 1st of this year. So we're looking forward to that. We're going to give you more updates as that comes along. Right now, no one really knows what the sum defines. So we're looking forward to the final rule to, to kind of see what you would have to test or what you would have to send as part of this testing. Okay. Option number 2 is you can report to a reduced number of days. So for example, let's say that you currently don't have a patient portal or you don't have an EHR, and you do certainly want to participate and potentially get a positive adjustment. You're just not going to be ready immediately starting January 2017. That means you could report for a reduced number of days. So you're still reporting on all measures. So that's the difference between option 1 and option 2. Option 1 is you're just sending a test. You're sending some data, probably not all of the measures. Option 2 is you're reporting on all of the categories, all of the measures within the categories. You're just doing so for a reduced number of days. So originally the proposed reporting period was going to be a full year. They're saying you can now report for a reduced number of days to not only avoid the negative adjustment, but to also potentially get a small positive adjustment. Now, just as with the sum data unknown, the reduced number of days is unknown as well. So we don't know for sure yet what they define as a reduced number of days. Is it going to be 6 months? Is it going to be 3 months? We don't currently know that, so stay tuned. We're going to find that out starting November 1st when the final rule comes out. Option 3 is your full year reporting period. So exactly what we just went over, you would be doing that for a full year. If you've done meaningful use, if you've done PQRS before, we recommend that you probably choose this route. If not this, then at least option 2. If you have done these programs before, don't just go with testing. Be ready because this is going to kick in 2018, so there's no point in delaying that. If you've done these things in the past, and you could potentially get a positive adjustment. So option 3 is full reporting period, the way that it was originally proposed for an entire year. And then option 4 is if you're part of an advanced APM, so if you enrolled for CPC Plus, which I know some of our providers have, if you're part of the Medicare Shared Savings Program, Track 2 or Track 3, then you would be also excluded from participating in 2017 MIPS. Now, there are some providers that are probably not even going to send a test and get a negative adjustment. Let's not let that be one of you. Make sure that you use one of these available options to at least avoid negative adjustments. Okay, and then the last slide for the day, we will finish our series of MACRA webinars with these. MACRA, M for micro-eyes, A for accountability, C for certified EHR, R for research, and A for ask. If you're overwhelmed, if you're not sure of anything, how to run your reports, not sure where to start, not sure what you should look up or how do you know where to even begin, let us know. Let's talk about it. Let's get you to the point where you at least have a starting point. Or if you participated in programs in the past, then start writing your reports. If you forgot how to, give us a call. We want you to be successful. That's what we're here for. These are hard on physicians. There's a lot of reporting. It's not how you're used to doing things. So let us help you. That's what we're here for. Accountability, as Justina mentioned already, get together in your office. I know that currently, when we ask practices who's responsible for meaningful use or who's responsible for PQRS, we'll almost always get an answer, well, everyone is involved in it. Yes, the entire office is involved, but you should have one person in the office that is accountable for running reports, for, if Jessica is responsible for, let's say, inputting patients' medications and Danielle is responsible for checking the person in, someone should be running a report and let Jessica or Danielle know if, they're falling behind in the measures that they typically take care of. So while it is an effort on the entire office, there should be one person that's going to be responsible for letting people know if a specific measure is behind, or just staying on top of the report, staying on top of the updates to MACRA, staying on top of the program, researching it, signing up for CMS and micro-eyes webinars and newsletters, just kind of be an expert in the program. Certified EHR, if you don't currently have that, obviously it's one of the requirements for MIPS. You will need to run your reports. You will need to report on these things. So if you don't currently have a certified EHR, reach out to Justina and she'll be able to guide you in the right direction. Research, that's the best thing that you can do. That's how we got all this information. There are a ton of webinars out there available on the CMS site. Just research it. There's so much information online, it can get overwhelming. Like I said, if you're not sure where to start, reach out to us. We'll guide you in the right direction, but make sure you stay on top of it. And then ask if you're not sure, or you don't understand something, just give us a call and ask. So with that, I'm going to hand it back over to Justina. She has some closing comments to make, and I wanted to thank you for joining, and I'll leave you with Justina.
Thanks, Vida. So I just wanted to add on to that and mention that we are your consultants, and we want you to feel comfortable coming to us with questions. We do this research for you because we enjoy it and we want to see you succeed. So we were going to actually get into the EHR and show you how to do some things, but we ran out of time today. So what we'll do is, this is the second of our series on MACRA. There are 4 total webinars. So during the last webinar, which is going to be a Q&A session, we will have a demo database available. So if any of you have questions on how to run any reports that are currently available, or meet certain measures for PQRS for this year, or any questions about MIPS going forward, we'll have that available, and we can actually jump into the database and show you, give you some suggestions on how to customize your progress notes. If you're currently using notes that were created for you when you first implemented the EHR technology, maybe you should have someone read over those. Possible you need some changes. If you implemented in 2011, that was 5 years ago, they're probably outdated. You may want to update them. So if anyone has any questions at this time, you can feel free to raise your hand or to write in our question box. I will unmute everyone as well so that if you wanted to speak up, you can go ahead. For those of you that said you're not sure if your clinicians are eligible, credentials are or who they are. All right, we're not getting any questions, so we'll assume that we just gave you way too much information and you're overwhelmed. So if in the next week or two you want to do some of your own research on MIPS, ask us some questions over that time, then we can have a full Q&A session in 2 weeks on October 14th, and we'll talk more about it then. So thanks everyone for joining again. I want to say you all back for meeting all of these requirements since you're here with us today, and we look forward to working with you.
Thank you. Thank you.